The topic will be evidence or entrenched, and it really relates to why do we do what we do. So one prong of this would be we give people 15 different topics and say go do it, but they realize it's hard to do. I think the other side is they invited Richard and I so that they could prove they didn't discriminate against the elderly. Is that right? Conflict of interest. I have an independent quality consulting data safety monitoring board relationship with Medtronic, and all those proceeds go to the Carolinas Healthcare Foundation. This will be a 4-part talk. I'll try to go through it quickly so that you're exposed to these principles, and then we can talk about it or follow up at some future date. So we're going to talk about threats to decision-making, quality, patient safety, as it's vital to consider common phenomenon and foibles for the individual, the team, and an institution. Secondly, how to recognize how information flows, innovation diffuses, how knowledge is managed. That's a lot of what we're talking about here. And then we'll talk about a couple of common examples of threats to quality and safety, and then ultimately the strategies. So we'll start with this understanding how decisions are made, that sort of thing. We recently wrote about this, talked about it. I think this is a great one. April 19th, 1995, 45-year-old man, standing 5'7", weighed 270 pounds, robbed 2 banks during the daylight, no mask. Surveillance camera footage shown on 11 p.m. news. Minutes later, tip was received. 1 hour later, MacArthur Wheeler was in police custody and stated, "But I wore the lemon juice, I wore the lemon juice." Apparently, Wheeler knew that lemon juice could be utilized as a key ingredient for invisible ink and thought his face would be invisible to surveillance cameras. In fact, he described that he tested the theory by experimenting with the lemon juice and Polaroid camera. Flawed information, poor judgment, and a poorly designed experiment, right? It's a true story. Look it up. How about Lake Wobegon, where all the women are strong, all the men are good-looking, and all of the children are above average? 88% of drivers in the United States rank themselves as above average. Software engineers from company A and B were individually asked if they were in the top 5% of software engineers, 32% of company A, 42% of company B. We all face this every day when we're talking to our teams and we're trying to get them to change, right? This phenomenon is illusory superiority, otherwise known as the Dunning-Kruger effect, right? And it highlights a poor performer's lack of skill and the necessary knowledge to identify their meager performance. And for those high performers like Rakesh and the people in Winnipeg, they don't even realize that everybody else doesn't get it, okay? So there's 2 edges to this. Interestingly, amateurs have been found to rate themselves comparable to experts in various endeavors that include, but not limited to, humor, grammar, and logical reasoning. Even college debaters, right? You'd think they're pretty clever. I have a debater in our family. Bottom 25% performers lost 80% of their debates, but estimate their winning rate at 60%. This goes on in chess as well, where there's numerical rankings, right? And you can predict mathematically, statistically, how likely you are to beat somebody that's ranked above you, below you. The less skilled, it's unbelievable how they still think, despite the math, that they're going to beat better chess players. Which brings Bill Murray into things. It's hard to win an argument with a smart person, but it's damn near impossible to win an argument with a stupid person. So it's not just that. There's what's known as inattentional blindness. Has anybody ever seen the invisible gorilla phenomenon? If not, type it in on YouTube, watch it. 50% of people, when they ask you to focus on this ball being passed, it's a white ball, you know, are doing that dutifully, and you get to the end and then they say, what about the gorilla? And you say, what are you talking about? You know, I counted the 13 passes. This gorilla walks right through and you never see it because you're focused on something else. Okay, so naive observers may overlook important information, and it's another phenomenon that may threaten decision making, but not just the unskilled. Take a look at this. This is a study. The invisible gorilla strikes again. Sustained inattentional blindness by expert observers. A gorilla 48 times larger than the average lung nodule was inserted within these CT scans, and 83% of the radiologists didn't see it. True story. Well, how do we think? We think fast and we think slow. Many of you have probably heard about the book or read the book, but it's a popular theory, something that I ascribe to. Fast thinking is that's learned by experimenting, trial and error, rules of thumb, best practices, intuitive judgment, common sense. And we have cognitive shortcuts known as heuristics, and with those there are biases to this unconscious quick thinking, okay? The archetype for the slow type 2 process are probability computations, which require time and mental energy. That's all you really need to know right now to think about this, so I won't read every word of it. Kahneman and Tversky are the people that talked about this and the biases, and they first reported on availability bias, representativeness, anchoring, simulation heuristic. Let's pick one of them just for an example, anchoring. If you're in a negotiation, that first number that comes out has a way of anchoring us, right? If I say, my house is worth $100,000, that's what I'm going to put it up for sale. Well, the guy then comes back and says, well, I'll give you $90,000, right? And I'm thinking, no, it's worth $100,000. That has a way of affecting the way we think, and it's the same thing in clinical medicine. More recently, published, and this was in HBR, a 12-point decision checklist. So there are ways that you could think about your biases or your team's potential biases and prevent yourself from making those mistakes. How about the wisdom of crowd? We've all read about that, right? It works when you're trying to figure out what's the way to the pig at the 4-H fair, right? They've proven this. So significant potential provided the group addresses potential problems of cognition, coordination, cooperation, and conditions of diversity and independence. Real-world clinical threats of eminence and eloquence and diffidence, and we've all seen vehemence, right? These are real-world things. Eminence, well, that guy, he knows more than anybody else. Well, they speak eloquently. Somebody else could care less. Somebody else says it was God's will, right? And then there's somebody else that just yells louder than everybody else, and they get a lot of attention. So why is this important? We're all working now in multidisciplinary teams, which brings us to the Abilene Paradox. Has anybody ever heard of it? Group agrees to do something despite the fact that privately most or even all members of group disagree on doing it, i.e. private opinion appears to contrast to what the overall or overwhelming opinion of the group is, which is, in fact, it's not. So the beautiful example, and this was, I think, 1974, it was elucidated. They tell the story of this family that's sitting, you know, it's a hot Texas day, and somebody says, boy, sure would be good to have lemonade, and I'm kind of hungry. Somebody says, well, why don't we go to Abilene? Great, yeah, we can go to Abilene. You know, back in the day, there's no air conditioning in the cars, and it's dusty, and it's hot, and it's sweaty. They go there, they eat at the cafeteria. It's not very good. They get back, and, you know, well, wasn't that fun? And finally, somebody says, well, not really. I mean, it was hot and it was dusty and, you know, food wasn't very good. But you said you wanted to go. Well, I went because you said you wanted to go, and so forth and so on, right? So have we ever seen this, like everyone goes even though nobody wanted to go? Absolutely. It's a phenomenon, okay? You have to use this wisdom of the crowd carefully, though, right? It works in things where it's really unknown and experts don't make a difference, as evidence here. These smug pilots, they've lost touch with regular passengers like us. Who thinks I should fly the plane? That's one of the fears, too, right? When you give everybody a voice. One of my business school professors said, when you empower stupid people, you just make bad decisions faster. Institutions. Jim Collins studied how the mighty fall. There's stepwise progress, hubris born of success, undisciplined pursuit of more, denial of risk and peril, grasping for salvation, capitulation to irrelevance or death. And it's this, we'll go through this. Undisciplined pursuit of more, I think that many of us fear, right? We're talking about going from a volume world to a value world. And Ed and I could be making a great pitch for why we should be doing something in the organization. And they say, I don't know about that. This is what we do. This is how we do it. So think about Kodak, dominated the photographic process and employed Steve Sasson, created a digital camera in 1975. Didn't want to disrupt itself, filed for bankruptcy in 2012. Why? Marginal cost, marginal revenue. That's how businesses are run. That's why Clayton Christensen talks about the disruptive innovation, that somebody comes from an outside world that doesn't make their money that way and interrupts it, right? And then what happens? Kodak says, what just happened? Undisciplined pursuit of more. They wanted to sell film and paper, right? Steve Sasson, here he is. When asked what was going on, management reaction was, that's cute, don't tell anyone about it. Here's another great one if you're interested in organizational behavior. It's one of the most noteworthy books, Evolutionary Theory of Economic Change, and Nelson and Winter sum it up. Much of firm behavior is best understood as a reflection of the general habits and strategic orientation from the firm's past rather than the result of a detailed survey of the remote twigs of the decision tree. In other words, whatever happened in the past is likely to repeat itself. So let's see, how does information flow and diffuse? Alex Pentland, who's an MIT professor, uses sociometry to study this, and he's basically said there's 4 stages: exploring, engaging, ideas, and then those things become habits. What does that mean? There's diverse ideas, dense interactions, which what they look like is a team talks, they finish each other's sentences, they nod, you know, that paralanguage, and that's characteristic of groups that perform at a high level. These decisions are found to be a combination of personal and social information. For example, when personal knowledge is low, we characteristically increase the weight of social information. This testimonial approach is commonly employed by patients seeking qualified medical and surgical care. If we don't understand all of this, and I have to tell you, I didn't understand all of this, I used to think that's the way it should be done, I do it. Well, guess what? I'm probably not like everybody else. That's why they like to have meetings, they want to talk about things. You've even heard, let's take it to the team, let's socialize it. There's a reason behind it. He wrote a great book, Social Physics, and he talks about finding the perfect balance between that isolation, Kevin sitting in a room and thinking of it and then telling everybody to go do it, and the echo chamber, you know, we're all repeating the same thing. And he has studies and data that prove these sorts of things. So I'm giving you sort of the qualitative view of this, but it's all been studied like the other things that we study. How about the diffusion of innovation? It takes place fairly slowly, but we all know the concepts of the laggards, the late majority, the early adopters, the innovators. But what happens when you look at this in healthcare is there's this recurrent theme. It's not 30% improvement. It takes 17 years from when we say that works to when it's generally accepted. The concept of the future is here. It's just not evenly distributed. So how about managing the knowledge? Well, we've organized ourselves through the AATS, the STS, that sort of thing, the workforce on evidence-based surgery, to have clinical practice guidelines. Think the prospective randomized studies. That's the tried and true way that we go about doing things. And we focus a lot on that. They have their strengths, their limitation. There's bias based on the efforts through study design, expert opinion, that sort of thing. And the rate at which information accrues and analyzes is also increasing, creates other challenges for us, like how do we do this in a most institutionalized way and still get it to people and then put it into practice? Well, let's look at a couple of those threats, if we will. How about bias? There's this study done, I want to say 2010 Circulation, Hannon in New York in this study. Cabbage indication, 53% were recommended for cabbage, 34% PCI. I mean, that's unbelievable to me. PCI indication, guess what? 94% get the PCI. How about you could get a cabbage or PCI? 93% get PCI, 5% get cabbage. So if you look at how we're organizing ourselves, again, what you're seeing is it's hard to do this stuff. There's a lot of bias. How about something as simple as transfusing blood after coronary surgery? What I try to show you here is wide variation, but when they studied this, the range was from 7.8 to 92.8% of programs transfused their coronaries with blood. Okay, What do we know? Study after study shows non-inferiority. 2010 track says with, the criteria they used, the group that gets transfused less doesn't do worse. Boom. 2017, we're still talking about the same thing. I looked at the STS data. Look at the rate at which we change, between 1.1% and 3.1% per year. And I can tell you that it's like 42, 43% national average for coronaries getting transfused. Our organization in 1 year went from 35 or so to something like 19%, just because we said we were going to do it. Again, it takes 17 years. So these consensus documents, it's here in this middle space, collective opinions of experts, that I think that we're working to try to forward the notion it gets to evidence-based practice instead of evidence-based medicine. Rakesh and a group of colleagues did a similar sort of thing with the post-cardiotomy arrest and what should we do. So finally, I'll quickly talk about a couple of strategies. We have to think in terms of patient, the practitioner, an individual, the team, and the institution. For the patient, it really gets to helping educate, engage them with this shared decision-making process and value-congruent choices. We shouldn't be doing things that don't fit with their values. As a practitioner, what I would suggest is you have to have a way of thinking about things. And at the bottom, what I describe is this paradigm of simple, complicated, complex, and chaos, and the process and what the people do. So if it's simple, it should be a pathway. That's what your nurses and your RTs do. If it's complicated, there's an algorithm, and that's what your NPs and PAs do. If it's complex, I say arm somebody with considerations. What do they think about? That's typically a doctor. And when it's a chaotic or very high-risk situation, considerations, teaming, and that's where your heart team comes into play. So what do? We ask for feedback as individuals. We try to continuously learn. I think importantly here, when arguing with a fool, make certain the other person isn't too. Know a bit about these biases. I'll skip through this. We're short on time. Here's a good one. We don't want to reinforce what we already know. You Google it. Literally the first link that agrees with you, you already believe, jackpot, right? People say I'm egocentric, but enough about them. We really have to be careful about our influence, our biases on these things. How about the team? A recommendation would be to quantify risk, institutionalize your risk mitigation strategies. These processes slow the diagnostic process, promote institutional learning where data is converted to tacit knowledge and operational routine. And what I mean by that, if this is the way we do it, everybody knows it, and they see the deviations, and then they're deputized to help. Reliable statistic evidence will outperform the availability heuristic every time. Thaler and Sunstein, who you've probably read about. Numbers don't lie. That's where we come in. The way I've thought about this, it's almost like we still work in a world that doesn't realize that Moneyball was never written, okay? We wrote about this recently, and what you really want to do is, where you can, slow down, quantify risk, and routinely apply risk mitigation strategies, some of which we're talking about today. I won't go into all the details, but again, the idea flow, you have to think about that. I love this. The best part, it takes 75% less than the normal idea, right? Because it's a new bulb. Okay, so Brent James suggests that this impactful clinical process should be identified, evidence-based practice built around the process, should blend into clinical workflow that doesn't rely on human memory. Why? You eliminate the biases. It's got to be integrated with a learning system that combines data, computerized analysis, and an expert at the interface of the system and the clinical environment. Joint Commission similarly says we should be aware of and enhance knowledge of these cognitive biases, professional reasoning, critical thinking, decision-making skills, and enhance the work system conditions and the workflow that design that effect on cognition. So I gave you a lot, but hopefully it stimulates a few thoughts. You'll go read, and certainly we can talk more about it. We did just write this up, I think it was last month in Annals, so there's something there for you to look at. And thanks to ERAS, thanks for everybody coming, certainly the AATS and the board.